Welcome to Diseases Simplified, the podcast that breaks down medical science into clear, accessible conversations. Hosted by a U.S. board-certified medical doctor, this show is designed to help you understand your body, your symptoms, and the science behind common diseases without the medical jargon. Whether you're a curious listener, a student, or someone navigating your own health journey, you're in the right place for reliable, simplified, and evidence-based information. Let's make medicine make sense together.
Welcome to the Deep Dive. So if you've been online or, just listening to people talk lately, you probably noticed there's this huge buzz around new weight loss medications.
Oh, absolutely. They're everywhere. Headlines, social media.
Exactly. And you hear all sorts of stories, right? Some sound almost miraculous. Others are just confusing. So today, we want to cut through that noise.
Get down to what's really going on.
Yeah. Our mission with this deep dive is basically to unpack the whole world of these anti-obesity medications. We'll look at the newest injectables, the ones everyone's talking about, but also some of the established oral treatments too.
The goal being to help you, the listener, really understand what they are, how they actually work, who might be a good candidate.
And crucially, what to expect if you or someone you know is considering them. We want you to be well informed, especially if you're thinking about options for managing obesity as part of your own health journey. Okay, so let's unpack this. The information we're drawing on today comes from expert presentations. We're talking family physicians, board certified in obesity and lifestyle medicine. So real world clinical perspective.
Yep, your insights, yeah.
And the big takeaway message, I think, right from the start is that obesity, it's complicated. It's a chronic disease. Managing it successfully, it usually takes a really comprehensive long-term approach. It goes way beyond just diet and exercise.
That's such a critical point. It's not about willpower, it's physiology.
Physiology.
Okay.
So let's start there. Redefining obesity.
Right. We really need to understand obesity not as a simple choice, but as what it is. A complex, chronic, progressive, often relapsing, but importantly, treatable neurobehavioral disease.
Neurobehavioral.
Yeah.
So involving the brain and behavior.
Exactly. And it's influenced by so many things: genetics, our environment, hormones, behavior. It's a mix. There's even a push to change the name, maybe to adiposity-based chronic disease or ABCD.
ABCD. Why the change?
Well, partly to reduce the stigma around the word obesity, but also to really hammer home that it's a chronic medical condition like diabetes or high blood pressure.
And it's widespread, isn't it?
Hugely. Globally, the latest data from 2022 shows about 1 in 8 people are living with obesity. And here in the U.S., it's around 42.4% of adults classified as obese, plus another 30.7% who are overweight.
Wow. So a massive health issue.
Truly, it really underscores why it deserves a proper medical approach, not just judgment.
Which brings us back to that point about lifestyle changes. Diet, exercise, they're fundamental, right? Everyone agrees on that.
Absolutely foundational, non-negotiable, really.
But often for sustained weight loss, especially significant weight loss, they're just not enough on their own for many people. Why is that? Why is it so hard?
It comes back to that physiology we mentioned. Your body actively fights against weight loss. It's a survival mechanism, essentially.
Fights back.
Okay, so one major way is something called metabolic adaptation. When you cut calories and lose weight, your body goes, whoa, famine maybe, and it slows down your metabolism.
Yeah, that makes sense. You weigh less, you burn less.
Right, but it slows down more than you'd expect just from the weight loss. For a 10% weight loss, your metabolism might drop 20-25% more than predicted based on the change in body mass alone.
20 to 25% more. That's significant.
It's huge. Remember that Biggest Loser study? Years later, the contestants' metabolisms were burning, on average, something like 500 calories less per day than expected for people of their size.
500 calories.
Right.
So your body is actively working against you, keeping the weight off.
Exactly. And it's not just metabolism, there's also appetite adaptation. As you lose weight, your body cranks up hunger hormones and dials down satiety hormones. You feel hungrier, less full.
Oh man. So it's a double whammy. Slower metabolism and you're hungrier.
Precisely. It's not a failure of willpower when someone struggles to maintain weight loss. It's a powerful physiological response trying to get back to that higher weight.
That really changes the perspective.
It should. Think about it. We wouldn't tell someone with pneumonia to just, try harder to breathe better. We give them antibiotics.
Right. You treat the underlying infection.
Medications for obesity, in many cases, are like those antibiotics. They help counteract these physiological adaptations, disrupt those hunger signals, and give lifestyle changes a much better chance to work long term.
Okay, so that's the perfect setup. If our bodies are wired to resist, what are these medications actually doing? Let's talk about the ones making headlines, the GLP-1s.
Right, the GLP-1 receptor agonists. These are really the new frontier everyone's excited about.
What are they fundamentally?
So they're medications that mimic a natural hormone your body makes called GLP-1. This hormone is normally released when you eat.
Okay, so like a natural signal, what does it do for weight loss?
Primarily, it works in a few key ways. It boosts satiety, that feeling of fullness. It slows down how quickly your stomach empties so you feel full longer. And crucially, it acts on the brain, specifically the hypothalamus, to reduce overall appetite and food intake.
Oh, so it tackles both the stomach side and the brain side of hunger.
Exactly. It's quite elegant, biologically speaking.
And you mentioned they were initially for diabetes?
Yeah.
But they seem to do more.
That's what's fascinating. Yes, first for diabetes, they help insulin work better, reduce glucagon, but we're seeing benefits way beyond blood sugar.
Like what?
Well, potential benefits for fatty liver disease hepatologists are already using them off-label for that. Also, positive signs for kidney disease, maybe even cognitive function, neuroprotection.
Wow.
And the big one, cardiovascular benefits, reducing heart attacks, strokes. It's almost like gabapentin, how it ended up helping with lots of different things. It kind of reminds me of that, a multitasker.
A true multitasker.
Yeah. Okay, let's trace the evolution a bit. What was the first GLP-1 approved specifically for weight loss? That would be liraglutide, brand name Saxenda. It's a daily injection. On average, people lost around 7% of their body weight.
7%.
And a key update there, it just went generic. So that could make it much more accessible cost-wise.
Good point. Then came the one that really shook things up. Semaglutide, Wegovy for weight loss, Ozempic for diabetes.
Yeah.
That's weekly, right?
Correct, weekly. And definitely a game changer in terms of efficacy.
Why is it so much more effective than liraglutide?
Several reasons. It binds more tightly to the GLP-1 receptors. It lasts much longer in the body, a full week versus about 13 hours for liraglutide. It seems to get into the brain more effectively to target those hunger centers, and it slows stomach emptying even more.
And the results reflect that.
Oh, yeah. Average weight loss with semaglutide is around 15%, double what liraglutide offered, roughly.
15% is substantial. And this is the one with the cardiovascular approval you mentioned.
Yes. This is huge. Semaglutide, specifically Wegovy, is now FDA approved to reduce the risk of major adverse cardiovascular events. We're talking heart attacks, stroke, cardiovascular death in people with obesity or overweight who also have established cardiovascular disease.
So that's why Medicare Part D started covering it for some people.
Exactly. If you have obesity or are overweight A&D, you've had a heart attack, stroke, or have peripheral artery disease, Medicare Part D may now cover Wegovy. But important clarification, just having high blood pressure isn't enough on its own for that coverage. You need that history of a major event.
Got it. That's a big step for access, at least for that specific group. Okay, who's the newest player?
That would be tirzepatide, marketed as Zepbound for weight loss, Mounjaro for diabetes, also a weekly injection.
And what makes tirzepatide different?
It's what we call a dual incretin agonist. It hits the GLP-1 receptor, like semaglutide, but also another receptor called GIP, or gastric inhibitory polypeptide.
2 targets instead of 1. Does that mean even more weight loss?
It seems so. Studies show average weight loss around 17.8%, but some people, especially at the higher doses, are seeing 25% or even more.
Yeah.
That's like getting into the range of results we see with bariatric surgery.
Wow. Comparable to surgery. That's incredible. And what about side effects compared to semaglutide?
Anecdotally, and in some studies, patients seem to experience fewer GI side effects like nausea and vomiting with tirzepatide. That dual action might provide a sort of balance, making it potentially more tolerable for some.
Interesting. So better results potentially and maybe fewer side effects for some folks?
It appears that way, yeah. And the pipeline doesn't stop there. If we look ahead.
There's more coming.
Oh, yes. There's a drug called retatrutide in trials now. It's a triple agonist, hits GLP-1, GIP, and a third receptor, glucagon.
Triple. What are the results looking like?
Early phase 2 trial data showed weight loss around 24.2% at the 12 milligram dose. Even more dramatic.
24%. I mean, if we connect this to the bigger picture, is this kind of drug going to eventually retire our bariatric surgeons?
Well, maybe not retire them, but it certainly raises questions about the future landscape of obesity treatment. It's incredibly promising. We have to watch how the phase 3 trials pan out, of course.
Okay, so these GLP-1s and the dual and triple agonists coming, they're clearly revolutionary. But they aren't the only tools, right? What else is in the toolbox?
Absolutely not the only tools. A good obesity management plan often uses various options. We still have several established oral medications.
Right, the pills. What are the main ones?
Well, there's orlistat Xenical prescription, Ali over the counter. It works by blocking some fat absorption in your gut.
Sounds straightforward. Any downsides?
Oh, yeah. The main issue is GI side effects, cramping, gas, oily spotting, or leakage. It requires a very strict low-fat diet to minimize those, which can be tough. Because of the side effects and only moderate weight loss, it's not a go-to for most obesity specialists these days.
Okay, so probably not top of the list for most. What else?
Then there's Phentermine. This one's an older medication, a stimulant actually approved way back in 1959.
Still used.
Widely used. It's very affordable, which is a big plus. It primarily works by reducing appetite, increasing satiety. Many people describe it as feeling like having a strong cup of coffee.
Side effects. Being a stimulant.
Yeah, you can get dry mouth, insomnia, maybe an increase in heart rate or blood pressure, so monitoring is important. But interestingly, current guidelines actually support its long-term use for many patients, which wasn't always the case.
Okay, affordable and effective for appetite. Then there's a combination pill.
Right. Phentermine topiramate ER, brand name Qsymia. This is actually the most effective oral option we have, typically giving around 10% weight loss.
10% from a pill is pretty good.
Yeah.
But I feel like there's a but coming.
There is a big but, especially regarding topiramate. It's teratogenic. It can cause serious birth defects. So for any woman who could potentially become pregnant, it's crucial. Monthly pregnancy tests and using 2 reliable forms of birth control are required.
That's a serious consideration. Any other common side effects?
Topiramate can sometimes cause cognitive issues. People jokingly call it dopamax because of brain fog or trouble finding words. Also, tingling or numbness, called paresthesia, and an increased risk of kidney stones.
Okay. But you mentioned a weird bonus side effect.
Yeah, a little pearl. Topiramate can make carbonated drinks taste flat or metallic. For people trying to kick a soda habit, that can actually be helpful.
Unexpected perk. What other oral meds are common?
There's naltrexone bupropion ER or Contrav. This one works more on the brain's reward pathways related to food.
Reward pathways. So good for certain types of eating.
Exactly. It seems particularly helpful for hedonic eating for pleasure, craving, or comfort, rather than actual physical hunger.
Common side effect?
Nausea is the most common one, especially when starting. And there are contraindications. People with seizure disorders, certain eating disorders like bulimia, or those taking chronic opioid pain medications shouldn't use it because of the naltrexone component.
Got it. Are there any other, maybe more specialized medications we should mention briefly?
Sure, lisdexamfetamine or Vivance is approved, but only specifically for binge eating disorder, not general weight loss.
Go ahead.
Metformin isn't technically an anti-obesity drug, but many doctors use it, especially if someone has insulin resistance, prediabetes, or PCOS. It helps with the underlying metabolic issues and can make lifestyle changes more effective.
Kind of helps the body respond better.
Exactly. And then there's a very specialized drug, setmelanotide, Imcivree, but that's only for extremely rare genetic conditions that cause severe obesity, not something most people will encounter.
Okay, so we've covered a lot of ground on the what? GLP-1s, orals. But let's circle back to something you said earlier, lifestyle. Diet and exercise are still foundational.
Absolutely non-negotiable. These medications are tools. Powerful tools, yes, but they work with lifestyle changes, not instead of them.
They help you stick to the plan, maybe see results faster, which can be motivating.
That's a huge part of it. Seeing progress helps maintain momentum. I can even share, personally, I lost about 65 pounds using lifestyle changes and medication. My husband, around the same time, used medication but didn't really stick with the lifestyle part. He lost about 35 pounds but regained more because the habits weren't there.
That's a really clear illustration. The medication gives you a boost, helps control the physiology, but the habits have to change too.
Precisely. And just to remind listeners about eligibility generally, it's a BMI of 30 or higher, or a BMI of 27 or higher if you also have a weight-related health issue like high blood pressure, sleep apnea, or type 2 diabetes.
Okay, practicalities. Let's talk side effects for the GLP-1s mainly, since they're so common now. What can people expect, and how do they manage them?
Good question. Most common are definitely GI issues. Nausea is probably number one.
Right. What helps with nausea?
The good news is it often gets better over time. Tips include eating small, frequent meals. Eat your protein first. Eat slowly. Don't drink too much fluid with your meals. Maybe drink between them. Avoid really fatty, greasy, or super spicy foods. Caffeine and alcohol can also make it worse for some.
Simple remedies?
Ginger tea can help. And if it's persistent, your doctor might prescribe an anti-nausea medication like Zofran, especially when you're starting or increasing the dose.
What about constipation? I hear that's common too.
Very common, especially as the dose goes up. Key things: lots of water, increase fiber, maybe add a supplement like psyllium husk. Gentle stool softeners or Miralax are often recommended too.
And the opposite, diarrhea.
Can happen. Sometimes identifying trigger foods helps. Dairy can be a common culprit when starting these meds. Fiber can actually help bulk things up, paradoxically. Probiotics might be worth trying too.
Okay. Any others? Reflex?
Yeah, dyspepsia or reflux can occur. Same advice often applies. Avoid large meals. Don't eat too close to bedtime. Identify personal trigger foods. Over-the-counter acid reducers like PPIs or H2 blockers can be used if needed.
What about at the injection site?
Sometimes redness, itching, or a small lump, usually mild. Topical steroid creams or antihistamines can soothe it.
Are there any serious, though rare, side effects people should know about?
Yes. Though uncommon, there's a risk of gallstones or pancreatitis that would typically present as severe, persistent abdominal pain, often radiating to the back, maybe with vomiting. That needs urgent medical evaluation.
Okay. Important to be aware of the warning signs. What about mood? There's been talk about that.
Yeah, there has been some discussion. However, the current data doesn't really show a strong link between these medications causing depression or worsening mood. It's always important to consider other life stressors or even how medications are being absorbed if mood changes occur. Definitely talk to your doctor if you have concerns.
Right. So managing side effects is key.
Yeah.
But what about the long game? Are these medications something you take for a few months and then stop?
Generally, no. That comes back to obesity being a chronic disease. Like medications for high blood pressure or diabetes, these are typically meant for long-term management.
So if you stop taking them?
The physiological drivers, the appetite signals, the metabolic adaptations, they're still there. So weight regain is unfortunately very common, often most or all of the weight lost. It's not a failure, it's the disease reasserting itself without the treatment.
That's a really important expectation to set. What about plateaus? People hit those, right?
Yeah.
Where the weight loss just stalls.
Absolutely. Plateaus are normal. When that happens, it's really time to double down on the lifestyle side, optimizing diet, increasing physical activity, especially strength training. Sometimes, if someone's truly stuck despite best efforts, a doctor might consider adding a second medication from a different class, maybe an oral med alongside an injectable. But lifestyle is the first place to focus.
Makes sense.
No.
The elephant in the room. Cost and access.
Ugh. Yes. This is honestly the biggest barrier for most people. These medications, especially the newer injectables, are very expensive.
And insurance often doesn't cover them.
It's patchy. Coverage for weight loss medications is still inconsistent. Many plans exclude them. Sometimes manufacturer coupons or savings cards can help significantly, maybe cut the cost in half, but even half can be unaffordable for many.
And a Medicare. You mentioned the specific cardiovascular coverage for Wegovy.
Right. Outside of that specific indication, obesity, overweight, plus a history of heart attack, stroke, or PAD, Medicare. Part D generally does not cover these drugs purely for weight loss. It's a major gap.
So given the different meds, the side effects, the cost, it sounds like treatment has to be really personalized.
Absolutely paramount. It's not one size fits all. A good plan considers the individual's specific health profile.
Thanks for listening to Diseases Simplified. This episode was created with the aid of AI technology, including voice generation, to improve clarity and accessibility. All medical content is based on current literature, carefully curated and independently reviewed by a U.S. board-certified physician. Please remember, the information in this podcast is for educational purposes only and should not be taken as medical advice. Always consult your own healthcare provider for diagnosis and treatment tailored to your needs. Stay curious, stay informed, and we'll see you next time.